Are you interested in seeing less patients and making more money? Welcome back to another episode where I help younger physicians decrease stress and increase income by transitioning from corporate to independent practices, even without any business experience. So in this replay episode that I recorded a couple of years ago with Dr. Joseph, he describes how managed care has helped him reduce patient volumes while increasing revenue, and how discovering the value-based care strengthens physician-patient relationships and improves outcomes. So listen into this replay episode, and we hope you enjoy it. Today, we have the honor of having a good friend and a colleague, Dr. Brunel Joseph, on the podcast, but it's been a long time coming. We had 2 failed attempts, and it's been an impossible mission trying to get Dr. Joseph on. The first time, we actually recorded from your office, right? I think.
Yes.
And, I feel like I'm getting old. I'm telling stories now, so I'm going to tell this story. So we recorded in your office. We had a great conversation. I thought it was great. And you hung up, I hung up, and I tried to play it, and it was gone. There was no audio. And that was almost a year ago.
Yes.
I was embarrassed, and I think Dr. Joseph would be the only person that I could actually muster the courage to say, hey, could we do it again? So he came to my house. We were in a rental, and I said, we're going to do it live, and we'll record it then. Well, we recorded it. We had a very good episode, and it was garbage again. So for those podcasters out there, for those who they're trying to do something different, let me tell you, it was hard for me to ask Dr. Joseph to come back, but he did. And here he is, Dr. Brunel Joseph. Thank you for coming on the Practice Impossible podcast. And we're so happy to have you. And, why don't you tell us a little bit about yourself, or maybe even catch up with life? Because, I haven't seen you in a couple of weeks and months. So what's been going on?
Yes. Thank you so much. Thanks for having me. And, I appreciate the opportunity to be here. Well, it's been busy, for what we do. We are working every day, but between now with family, when we started this, it was just me, a single guy, working every day, but now family's growing.
Yeah. So you say family, I know you got married.
Yes.
So tell us about how marriage life is. And you're past the honeymoon stage, right? Because you're past a year, right?
Oh, yeah. My goodness. Yes. Well past a year, 2 kids now. Daughter is 3.5. My son is 2.5.
Are you kidding me? 2.5 already? It's been 2.5 years?
Yes.
Wow.
Time flies.
And your wife, is she working or where?
So my wife has actually been home since through the pandemic, and with the kids being so young, at this stage, she's starting to... she wants to go back. I mean, she's been itching to go back to work, and she's starting to get to do some coverages and things like that to start to kind of fill it out and see what she wants to do. But
what does she do again?
She's a chiropractor. She's a chiropractor,
okay.
And she has her own practice, which she closed that down when the pandemic hit. And at the time, she was pregnant. So the pandemic, and baby came early also.
That's
so
right.
we needed to super early. So we kind of needed to close things down. And now we're in the process of thinking of going back and open again.
Okay. Now, when you say open again, open to have another baby or open another practice?
No. The baby thing is done. We have 2 beautiful kids, a boy and a girl. We have the perfect set. So we are done.
Right.
No more babies.
So why don't you tell our audience, what do you do, how you end up in Spring Hill, and your background?
Yes. I'm a primary care physician with sports medicine background, sports medicine fellowship trained. Currently, we practice basically 100% managed care, almost 100% managed care.
Mm-hmm.
I came to Spring Hill. I was doing my residency in Illinois at the time, originally from Haiti, tropical guy. Moved to the U.S., ended up in Illinois doing residency. I wanted to get back to Florida. That's where most of my family is. At the time, my mother was in South Florida, and she was older, and I wanted to come being in Florida so I can be closer, spend more time with family. And I interviewed with Access Healthcare, And at the time, I was supposed to take a position in South Florida and Port St. Lucie. And they told me to come and see most of the operation is up in Hernando County.
Mm-hmm.
And they told me, hey, I want you to meet this young, smart doc that we probably would want you to work with. And the rest is history. I came up and it's been over 10 years now.
Yeah. So that, I'm not sure why he said young, but that doc was me, and was not young. And we were looking to expand the practice, and we definitely enjoyed having Dr. Brunel Joseph in our practice in Spring Hill. But then, life happened to me, and I ended up having to give up the Tampa office, right? So you took over the Tampa office. But even before we get into that aspect, you said you're from Haiti.
Yes.
Were you born in Haiti or raised?
Born and raised in Haiti, moved to the U.S. as a teenager. I was 19 when I moved here.
Okay. So you did, they call it secondaire in Haiti?
Yeah, in Haiti, yes.
In French?
Yes.
French school?
Yes. And moved here, went to UF for my undergraduate degree and ended up staying in Florida.
Mm-hmm.
And ended up, again, moving back to, I've been around I moved back to the islands for a few years, moved to England, did some of medical training there.
Okay.
And in England, go to Illinois for my residency and fellowship, and came back to Florida.
I'm not sure if I knew that about you, about the England part. What do you think is the biggest difference that you saw in British medicine in Europe versus medicine here? What was the biggest difference?
Well, the biggest difference obviously is the payer, right? You have one payer, mostly. In England, you have the National Health Service, the NHS.
Mm-hmm.
Funded by the government, and only a selected few people can afford to get a private insurance on the side if they do not want to wait on the NHS. Like we all know, if it's run by the government, it's slower.
Mm-hmm.
If you need something done, if it's urgent, it's going to get done. If it's emergent, it's going to get done.
Okay.
But it was the slower pace in the National Health Service. I'll give you an example.
Okay.
In England, if you need a knee replacement, for example, that's an elective surgery. It might be important, but it's not emergent. Then you might have to wait online for a few months.
Months?
Yeah, maybe could be even 6 months.
Okay.
Yeah.
So you see the physician, they schedule you. Is it because the scheduling is so far out, or because they don't have enough physicians?
Well, it's a combination of things. So the way the National Health Service works is that we go to med school. When you're done, you have to spend some time working for the National Health, the NHS.
Okay.
But those same physicians, particular surgeons, they also have their private practices that they run,
mm-hmm.
right? So an example, if you come to me as an orthopedic surgeon on the NHS service, it's going to take you longer. Things are a little slower there. But I can go next week to my private practice and do it for you privately. So that kind of, again, I'm saying the negative part of it, right?
Yeah.
Obviously, the positives are, yes, you pay more taxes, but you are covered on the insurance for emergencies or for medical care. It's all covered that way, but you're not going to get the service the way, it's not a fast service like it is here in the US.
So sorry, we distracted from that because I was always interested in finding out what your personal experience was, because you've done both.
Yes.
So you did your residency and fellowship in Illinois.
Yeah.
And you decided to do sports medicine.
Correct.
So I know that remember having conversations with you and saying you wanted to do sports medicine here. You were thinking about being a team physician.
Yes.
And did you ever do that? I can't remember.
Yeah, I did some coverages. I covered some teams, college and high schools. When I came back to Florida, what I really wanted to do is a mix.
Mm-hmm.
I wanted to do practice I can do my general managed care practice. And I had that vision of having my sports medicine and doing sports injuries and concussions and things like that on the side. But I kind of soon realized that managed care really demands your full attention in terms of the things that you need to do to be there for your patients.
Mm-hmm.
And we'll talk more about that in terms of it's not you come in and I take care of your headaches and bye-bye, right? You're responsible for the comprehensive care of that patient. And so that requires a lot more. So then I decided to focus more on managed care. And that was a good decision on my part.
Yeah. So when did it click for you that managed care was a good decision? I know that, some physicians still are practicing fee-for-service. They're doing a lot of injury medicine or how should I say auto accidents and things like that? When did you feel that it kind of clicked for you?
Well, when I really kind of realized and managed care, the preventative care piece is very important, right? So we need to do more prevention. I mean, I saw a quote, if we could eat better and exercise, we can prevent 70% of the diseases and the money that we spend on healthcare in this country, right?
Yep.
So it clicked for me when I realized I didn't have to see 30 patients in a day. I didn't have to see 35 patients in a day. I could see 10 patients a day and spend time with those patients, do good preventative care. And in terms of the financial reward, is probably better. So I feel better because I'm taking better care of that patient. I spend more time with my patient. And also the financial reward was also better. So it kind of clicked for me there.
So what do you say your colleagues are doing? Do you talk to your colleagues about what you do or your former residency training colleagues?
Most of my colleagues that I went to school with are still doing fee-for-service. Some of them are my sports medicine guys. Some of them chose to do 100% sports medicine. And some do primary care, but not sports, but not managed care either. So it's mostly fee-for-service. Mm-hmm. And most of them are in the grind. They are seeing 30 patients, 25, 30 patients a day. I mean, if I remember correctly, you have to to break even, you have to see at least 17 patients or 20 patients a day. And to make a profit, you have to be in the 20s, 30s. So in terms of fee for service, so it takes.
So are they seeing younger patients? Because I couldn't see myself. I mean, at this point, doing this 20 years now, I couldn't see myself seeing 20 patients. If I see 15 patients a day, I'm like, oh, that's a lot, because you do so much for your patients. How are they able to manage that? I mean, how are they able to do everything for the patients with chronic conditions?
Correct. So what's happening is most of these guys, they are not doing a comprehensive visit for that patient every time, right? Okay. If you have to see 30 patients, obviously, I'm going to take your blood pressure, give you the medication for that. Then you might have to come back for.
So you're churning them, but you're also having them have to come back to manage other problems. So it's one problem at a time. Yeah. So you've been doing this how many years now? 10 years?
10 years.
10 years.
10 years.
What would you say are 3 things that you really like about managed care? I think you mentioned one, but what are 2 more things?
I mean, the preventative care piece is very important to me because I think the fact that we are responsible for the overall health of the patient, then you take your time to do a lot of preventative care. And if I make sure that the colonoscopies are done, I make sure the mammograms are done, then we can prevent the colon cancer. We can catch the breast cancer early. Then the patient doesn't have to go through as much. We will not have to spend as much. So I like that managed care is really preventative care focus. That's one. Again, I mentioned the fact that the financial reward is better.
Yep.
For sure. And you build a better rapport with your patients as well, right? Because the patient you will make sure the patient knows that you're there for them. Mm-hmm. You're there for them weekends, day, 24/7. And my patient, they know to call me. It's my job. They know that I'm okay if they call me on Saturday because they have a burning question about something. Because of that, you build a better relationship with your patients. They will open up to you more. So I think those are the things that I really like the most about managed care.
Yeah, I agree with you 100%. And it's building those rapports. And I think I mentioned in the last episode, 5 reasons to embrace managed care is because if you see a 65-year-old patient, that 65-year-old may live another 15, 20 years. If you have a good rapport with them, you prevent care, and you do what you need to do to manage their care, they're never going to leave you. So that's guaranteed income.
Correct.
And even if they do leave you, I had one patient who left and he came back, with his, he was embarrassed to come back because he thought I was going to yell at him. And I said, no, I just want to know, why did you leave? Well, it was closer to my house. It was 15 minutes from my house. But doc, that other doctor was just yelling at me and pointing his finger in my face and telling me I have to do certain things. And I just felt horrible. I'll never leave you again. So I'm sure you've had those experiences.
I've had similar experience. I have the most recent one. Patient I've been seeing for a long time as well. And there's a group that came to town where they provided other things, including transportation. And that was the drive for her. They can pick me up from home, take me to the office. They do the x-rays in the office. They do everything there. And she called me to tell me, so sorry I have to leave. I'm like, that's okay. That's going to work better for you. But she came back because then she realized that they pick her up and they have to go pick up 15 other people. She's in a van for most of her day. And when she gets there, it's like she's a number.
Yeah.
And you know me. I can, it's like, that's why I came back because you know me and
yeah, it's all about the relationship.
It's all about the relationship. Family, yes.
Yeah. So what are 3 things that you would change? Things that you're like, oh man, this really sucks.
Things to change is the perception of managed care by other specialists, and even some primary care doc don't really get managed care. So there are some people you'll meet in our profession. You say, hey, I do managed care. They're like, for some reason, there is a negative connotation that some people have about managed care. And I think it's because the primary care doc controls. They feel like they control too much of the care. And the other things, I don't know if it's something I want to change, is just like, because it's managed care, it's more detailed, it's more involved. You are responsible for, it's a bigger responsibility, so to speak, right? You have a fee-for-service patient. They come in, let's say you did the bare minimum. They leave 2 days later, something happened. They end up in the ER. As a fee-for-service doctor, it's not, yes, it's my patient I care. I wish it didn't happen. However, you're not so on the hook, so to speak, for whatever happened to that patient outside of. So as a managed care person, the hospital called me, they text me and say, hey, I have your patient here. Can you see him tomorrow? Because I'm thinking about discharging. But if you can't see him, then I'm going to keep him here. Oh, I will see them. So it's like your responsibility for that patient continues.
Yeah.
Right? So what else I would change about managed care? Maybe on the patient side, some patients also don't recognize what managed care is. Mm-hmm. I still have some patients, and it's hard as a physician. You don't know what you can teach the patient, what you cannot. I have a patient come to me. Blood pressure was kind of elevated. I wanted to come back in a couple of days. They say, oh, that I feel bad. I don't want to abuse the system. They think if they come back to see me again next week, then I'm going to be billing the insurance. Mm-hmm. So there is an education part, both for physician need to be educated more about managed care and the general population as well. But it's like, how do you do that? How are you supposed to do that? There's that gray area of what you're supposed to tell the patient or not.
Yeah. And I think one of the things I find really difficult for me to even accept is some of the HEDIS measures. I don't know if
Yes.
There's a HEDIS measure that they're all over us. And if a patient has cardiovascular disease or even diabetes, they need to be on a statin drug.
Yes.
Sometimes the patients are intolerant to it. Sometimes their cholesterols are normal. So I haven't found a good study that tells me that if a cholesterol is normal, we still need to prescribe a statin. Long-term studies. I'm talking 20, 30, 40 years. So, and there's no way for us to get rid of that measure. So I find it a little annoying because as a physician, we should have the ability to say, hey, we should exclude this patient out of this criteria so that we can meet the measures, yeah. But, they want 85%, 90% compliance, which I think is a little crazy.
Correct. And the other part is like the patient, and that goes along with the patient's responsibility. The patient that blood pressure medication, they say the patient is not compliant, but sometimes the pharmacist sent it too early or the patient cannot tolerate it. And so you have all those measures that you're supposed to meet that can be challenging.
Yeah, absolutely. So what's the one thing you would tell a younger physician, such that by doing that one thing, it would make their lives much easier?
Oh, I would say being open to learn, right? Being open to learn and not just, and we both know we don't get trained in medical school for any of this. In terms of the financial side, the payers, out of training, I did not know the difference between fee-for-service and managed care. I heard about it and I wanted to acquire more. Mm-hmm. I wanted to learn and I felt like this was the way of the future. So I was willing to do that. Just like I said, some outside of even other physicians who don't know about managed care look at it a certain way. Outside of people coming out of training sometimes, and some of them are not even willing to learn because they've heard that certain things about managed care. So I think what I would say is to be open to learning about different payers, open to learning about different insurances, obviously open to learning more about medicine, because obviously you have so much more to learn once you finish training. Those are the things I would maybe get a mentor. That's something I thought about I should have done early. Get a mentor, because sometimes a lot of us are in our own little bubble. You don't know what the next primary care guy is doing. Even if there are certain questions you don't want to ask. You know how it is in terms of...
It's a competitive landscape. I mean, if you ask this question, or if you know what this guy is doing, he's going to take patients away from you. And there's so many patients out there. There's so much. You don't need to think that way. But those are great points, man.
Yeah, but even financially, so that's a big taboo also within our field. You can't talk finances. That's it.
And that's one of the biggest things we should be talking about. Because we're coming out of debt. And I saw I was on a Facebook group, a physician community Facebook group, and one of the questions from a physician, and I guess this is public knowledge because it's on Facebook, so I can say it, but he had 3 kids and he just came out of residency making $250,000 a year, and they're living in a 2,000 square foot home. They have debt. They owe people money, and he wants to buy a house. Should he buy a house? And I know you know the answer to this.
Yes.
The answer is
no.
Exactly.
No.
But the old me 20 years ago would have said, "Oh yeah, but you make enough money, and you should, get out of the rent." No. Pay off your debt.
Oh yeah, I mean that's another thing. When you said, "What else?" If I were to go back, financial education. Oh my goodness! In terms of, if I know then what I know now, I would be in a much better position today.
Yeah.
Right? Within the first 3 years of finishing, our responsibilities were not much. Mm-hmm. I was a single guy making good amount of money.
Yeah.
Because if you go back and think, okay, I was making good amount of money.
Yeah.
And it was just me.
Yeah.
So
I'll tell you what I was doing. I was flipping houses with student loan debt. What business did I have doing that? That's just nuts.
Yes.
But I did it, and we learned from our mistakes, and we're trying to, at the Practice Impossible, keep doctors from doing this type of stuff. So I think people are getting it. It just takes a little bit longer. And we need guys like you who can come on and share your experiences and tell us what we should do and what we shouldn't do.
Definitely, most definitely.
And I so thank you for coming on for a third time, but this one is actually recorded, and I see the levels on this machine going up and things are recorded, so I think we're good. I think we're safe.
And I'm happy to do it.
Thank you so much, Dr. Joseph, and we'll see you soon.
See you soon.
All right. Thank you so much for listening to the podcast. If you'd like to hear more, subscribe, follow in your favorite podcast app so you'll never miss an episode.